So this is a voided urine specimen coming from a 92-year-old male, and the patient had a history of colon cancer. And he presented with gross hematuria for a couple of days and come to our outpatient department. So on low power, so this is a voided urine specimen. On low power, we see some superficial cells, superficial squamous cells. So most of them were likely coming from the external genitalia, maybe from the urethra meatus or the like a foreskin. So when we screened the case, we noticed on medium power there were some smaller cells with scant cytoplasm and with increased like a nuclear hyperchromasia. So the specimen shows significant drying artifact. So the chromatin pattern is not very well preserved. However, you can appreciate that these cells do show increased size of the nucleus, a little bit polymorphism. The chromatin pattern seems to be a little bit coarse, and the cytoplasm is relatively scant. The contour of the nucleus is irregular, so it shows this angulated shape, and it forms a tight cluster. So this cell looks relatively atypical. So this is the type of the cells when we do the urine cytology screening that we want to see. So here another few cluster of cells. So again, quite hyperchromatic, and it's relatively degenerative, so the cytoplasm is not well preserved. However, you can appreciate the polymorphism between these nucleus of the cell. So you see hyperchromasia, irregular nuclear contour, relatively degenerated. So this cell again seems to be atypical. So throughout the entire smear, there were a few cluster of cells showing this type of feature, but relatively not well preserved. So this is a degenerated cluster. The nucleus is quite small. So it means that it has been degenerated and shrinkage of the nucleus. However, you can appreciate the hyperchromasia is also a little bit abnormal. So then we go to another circle. So here this is much clearer that this is a quite abnormal cluster of cells, relatively preserved. And in addition to the hyperchromasia and angulated nuclear coarse chromatin, we also see there are some cells shaping in these atypical spindling features, suggests that there might be some squamous differentiation. So based on the morphological pattern, so this is suspicious for high-grade urothelial carcinoma, and likely there were focal squamous differentiation. So squamous differentiation can be accounted for up to 30% of high-grade urothelial carcinoma. So it is not uncommon that we can see the high-grade UC with focal squamous differentiation. So these are quite obvious. The urine was initially screened as negative. So this is the cell that we want to look for in the voided urine specimen. So for the voided urine specimen, we can imagine the abnormal cell can be coming from throughout the entire urinary tract, from upper urinary tract, including renal pelvis, ureter, and to the lower urinary tract, including bladder. Usually for the primary bladder lesion, we will see more tumor cells. However, there are occasionally, sometimes we can see these like very scant tumor cells. And additionally, carcinoma in situ usually shed less tumor cell than the papillary tumor. And upper tract urinary carcinoma usually shed less in the voided urine specimen. So overall, this is the very first specimen for this patient in our hospital after the clinical presentation of hematuria. So hematuria can be due to urinary tract carcinoma, but it can also be due to such as like a stone or the other problem causing some obstruction. So if there is a stone, sometimes it will cause significant nuclear atypia, including hyperchromasia and irregulated angulated nuclear contour or nuclear feature. So for this specimen, although it seems to be very much like a high-grade urothelial carcinoma, but because we don't have any prior history from this patient, and the lesional cell is relatively scant, so for this specimen, we call suspicious for high-grade urothelial carcinoma, but this was initially screened as negative. So we need to pay attention that these cells are what we want to look for in the urine cytology specimen. So the positive rate for voided urine is relatively low. So with a low positive rate, sometimes we can miss a case, but just we need to remind us this is how high-grade urothelial carcinoma may look like, and how do we want to highlight the cell when we do the screening. So the next specimen is a peritoneal washing cytology obtained during the operation for ovarian cancer. So the patient is a 43-year-old female. So in the background, we see a lot of inflammatory cells and relatively scant cellular cluster. So for this specimen, we only have a few clusters of the cell showing striking nuclear atypia. So despite the scant cluster, I think this is definitely adenocarcinoma. That the nucleus show prominent hyperchromasia with a very tight three-dimensional architecture. At the edges that you can see through the nucleus, and you see a cherry red nucleoli and with bubbly cytoplasm. So this is a adenocarcinoma. And another tight cluster, this is also likely an adenocarcinoma. And this is relatively uncertain whether these are mesothelial cell, but this is definitely an adenocarcinoma. And the patient seems to have a high-grade serous ovarian cancer despite her younger age. So we will call this specimen as positive for adenocarcinoma. So next specimen, ascites specimen. The patient had a history of high-grade ovarian cancer. So this is very similar to the prior specimen. Instead, this is an ascites specimen, not peritoneal washing. But we can appreciate that in this specimen, we do see very high-grade adenocarcinoma. So it shows typical cytological feature for high-grade adenocarcinoma, including enlarged nucleus, vesicular chromatin, prominent nucleoli, and forming this tight three-dimensional architecture. Some of the cells do show bubbly cytoplasm. So this is a positive specimen and consistent with the patient's history of ovarian cancer. So next specimen is coming from a very young 28-year-old female. She came to our emergency department and with pleura effusion. So in this younger age, we don't expect that we will see metastatic cancer. However, just on a low power, we already appreciate that it does show some cells with much bigger nucleus comparing to the background inflammatory cell, and as well as hyperchromasia. So it is very dark staining just under the low power. And additionally, on this low power, we see a few cluster, but it does not form me actually like a very three-dimensional structure. But we do see there are some unusual like arrangement pattern that we call these Indian fires. So they are fires of cells in the like a specimen. So that is relatively abnormal. So low power feature is very important. So we rely on the low power feature to generate our initial round of differential diagnoses. And when we go to higher power, again, these cells do show typical morphological feature of adenocarcinoma. So we have big nucleus, chromatin pattern is vesicular. We do see like a prominent nucleoli. So initially for these relatively young patients, I was still thinking about lung cancer because rarely we can have lung cancer in the young female, and this is the pleura effusion specimen. Although, just like what I said before, it is not so common that we will have the initial presentation of these poorly differentiated form, like a single cell of lung adenocarcinoma. It's accounted for possibly less than 10% of our initial presentation. So then I checked the patient's history. She is a patient of invasive breast cancer. So it all makes sense because it doesn't very much look like lung adenocarcinoma based on the like arrangement pattern. However, just on low power, we already see there are areas showing these Indian fire pattern. So the Indian fire pattern, if you can Google it online, that in the ancient Indian American people, they would go to the hill for religious ritual, and they would just line with a torch and walking in a straight line together. So you see one by one by one by one in a line. So this is what we call Indian fire. Okay, so the pattern is compatible with metastatic breast cancer. So for the metastatic breast cancer, we would see cannonball, and another common pattern is what we show here is the Indian fire. So the next specimen is coming from a 69-year-old female, and this is a pericardial effusion. So pericardial effusion specimen, the positive rate is actually really high because this is the location. If you have nothing to do, you won't go to, right? So unlike, for example, a urine specimen, the positive rate is really low, and pericardial effusion, the positive rate is really high. And majority of time, about 70 to 80% of the time, we will see metastatic lung adenocarcinoma. So this is the case that we, from a 69-year-old female, and she does has history of lung adenocarcinoma, and we've already proved that in the pleura effusion specimen, it is positive for TTF1. So here, a typical morphological pattern for lung adenocarcinoma, tight aggregates of the cells, and highly atypical nucleus. Sometimes you will see cytoplasmic vacuolization. So this is positive. And for the cell block preparation, and we see tons of tumor cells. A lot of them are showing these micropapillary architecture. So this is one of the most aggressive architecture pattern that we can see in lung adenocarcinoma. So multiple micropapillary configuration. So we can use this specimen to do molecular testing. Going back to other urine cytology specimen. So this is coming from a 50-year-old female avoided urine specimen. So the patient had a history of another like a malignancy, which is epithelioid sarcoma. She received amputation, and there were multiple lung metastases, and she has been under our hospital for chemotherapy for a while. So in this specimen, it is relatively paucicellular. So in the background, we do see scant, like a superficial squamous cell, suggests that there are some contamination from the gynecology tract. However, we do see a single squamous cell cluster. So if you put this cluster of the cell in the pap smear, you will call these ascus, right? So we do see enlarge the size of the nucleus and of the superficial cell with a little bit coarse chromatin pattern and multinucleation, but we do not see callosity change. So we will definitely call this ASCA because the patient received chemotherapy. So supposedly she might have suppressed immunostasis, and then thus it's more easy to have HPV like a flare up and may causing some precursor like a CIN lesion in the cervix, and the cell might shade in the urine cytology specimen. So just like what we see maybe yesterday or 2 days ago, there's another specimen. So for this type of specimen, we will call these atypical. We see atypical squamous cells, and we suggest the patient to do a pap smear. So immediately, when we send out the report, the clinician just call me to asking, so what do you see? I say, it's all in the report. I see a typical squamous cell. So, and he say, so nothing else? You say, yeah, a typical squamous cell. And so you need to ask, so I say, you just need to ask the patient to do the pap smear. It's all in the report. And he keeps like asking, like it seems that he never go to gynecology for internship or something, rotation. So anyway, because we are like working in these highly like a subspecialized hospital, sometimes you really need to put it in the report, ask them to do the pap smear, and they will keep calling you again, say do the pap smear. I say it's all in the report. Yeah. So next, it's also a urine cytology specimen, 55-year-old female, and so this is not a voided urine. This is an instrumentive urine. So this is a ureteroscopic washing cytology from the renal pelvis. So it is from the upper urinary tract. So for the upper urinary tract specimen, because usually it's a washing specimen, we expect to see larger cohesive fragments of urothelial cells. Unlike in the voided urine specimen, usually we only see the individual single cell. So just on the low power, we do see some cellular aggregates as expected because this is a washing cytology specimen. But additionally, we also see a lot of single cell in the background. And most of the cells do show a relatively immature, high NC ratio appearance. So for the benign urine washing cytology specimen, we expect to see some like a significant portion of the cell were umbrella cell with big cell but the low NC ratio. However, in these specimens, we almost never see umbrella cell. Instead, we see a lot of these atypical cells, most of them showing these relatively like a irregular chromatin pattern. And some of the cells you can appreciate, it show really high NC ratio. So this cell is not a nucleated. It does have very scant cytoplasm around it. So unlike the usual pattern of high-grade urothelial carcinoma, I think for this specimen you can appreciate the chromatin pattern is relatively that we call hypochromasia. However, it does show irregular chromatin in this hyperchromatic nucleus. So this is one of the uncommon patterns that we can see in the high-grade urothelial carcinoma. Sometimes we see most of the lesional cells showing diffuse hypochromasia, but it still maintains other features including increased NC ratio, increased size of the nucleus, as well as irregular chromatin pattern. And so high NC ratio and large nuclear is a diagnostic feature. So these cells that are in the background showing this single cell pattern, which is easy for the diagnosis. than the aggregates of high-grade urothelial carcinoma cells. So sometimes aggregates of a cell is not easy to see the cytologic detail. However, in this particular aggregate, you can appreciate prominent polymorphism, right? Small nucleus, big nucleus, and we have individual cell choreoresis. And again, this is a very big nucleus and much smaller nucleus, all within the background. And they all show this very irregular chromatin pattern. So this is positive for high-grade urothelial carcinoma. So usually in the washing cytology specimen, if you have a lesion, and because the clinician must see the lesion and flush the lesion to collect the urine specimen, and you will see majority of the cells were lesional cell. They will be very, very scant, the normal cell in the washing cytology specimen if it is a positive specimen. So for this case, we will call this positive for high-grade urothelial carcinoma. And sometimes for the upper urinary tract washing cytology, because the subsequent clinical consequence might be quite severe, because the next step you might receive the patient's kidney. So I will usually just check the ureteroscope. So in the ureteroscope finding, the clinician do see a papillary lesion in the renal pelvis. So it must be coming from the mucosa, the urothelial mucosa. So there must be a tumor, and this is the cytology that we see. So this is a high-grade papillary urothelial carcinoma. So the next specimen is EUS-guided aspiration cytology coming from a 56-year-old male in the pancreatic body. So on low power, this is aspiration specimen, and we have a lot of cells. And the background seems to be quite busy. So when we go to higher power, this is a classic cluster of adenocarcinoma that we see the cell in polymorphic, variation in size and shape, and most of them showing quite prominent nucleoli. Additionally, in the background, we do see prominent tumor necrosis as well. So most of the cell in this specimen looks malignant. So again, very interesting looking cells and much smaller cells, and the distance between each nucleus is uneven. Some with a big gap, some is overlapping. So we see definitely disorganization. And the good thing about the aspiration, like a EUS-guided aspiration, is that it's not uncommon that you can see reference cell. So this is nice honeycombing benign ductal cell. And here, this is a cluster of adenocarcinoma. Again, this is adenocarcinoma, and this is benign acinar cells of the pancreas. And you can appreciate the differences in the size of the nucleus as well as the prominent nucleoli. So this is positive for adenocarcinoma. So another EUS-guided aspiration specimen. Again, we see hypercellularity and quite busy in the background. There are a lot of tumor necrosis, so prominent tumor necrosis, and the cells are hyperchromatic with a feature of adenocarcinoma. So for this specimen, it is highly necrotic. But we do see some preserved tumor cells, irregular nuclear contour, variation in the size, prominent nucleoli, irregular arrangement. So this is positive for adenocarcinoma. So next, let's move to some parotid aspiration. This is coming from a 62-year-old male. So this is a liquid-based cytology specimen. So in the background, we see cystic degeneration debris along with lymphocytic stroma. So this type of stroma is quite common that you can see in a Watson tumor. So in this type of background, what we are looking for is flattened sheets of bland-looking oncocytic cells. So this is what we look for. So this is a benign fragment of oncocyte with a very flattened arrangement. And the cells are relatively uniform in size, and the arrangement is honeycombing. So based on the cytological feature, we see benign large fragments of of oncocytic cell, and in the background of lymphocytic cystic stroma. So these combination equal to Warthin tumor. So this is a Warthin tumor specimen. So this is the direct smear. Again, sometimes you can see more blood because in the direct smear, we do not process the specimen to wash the blood, unlike in the liquid-based cytology. But we can also see like a nice flattened, like a very bland-looking fragment of oncocytic cells. So this is consistent with a Warthin tumor. So this is one of the most common tumor that we will see in the fine needle aspiration. Next specimen is also a parotid aspiration specimen coming from a 60-year-old female. So this is a totally different tumor. Just on low power, we can see there are some bluish material, bluish stroma. So these are chondromyxoid matrices. And in the background, we have a lot of single cells. And we don't have a cystic stroma, we don't have lymphocytic cells in the background, but we have these cells mostly in oval shape, some with a single cell plasmacytoid appearance. So these are all myoepithelial cells. So we have myoepithelial cells, we have chondromyxoid stroma, and sometimes we will see also cluster of the cell with a ductal type of arrangement. So if we see these three like a pattern together, these equal to a polymorphic adenoma. So for the polymorphic adenoma, usually we would like to see the direct smear for the loose stain or Ginza stain to look for the fibrillary matrix material, and it can be highlighted by this prominent magenta color. So there are a lot of different matrix producing tumor in the salivary gland, but the diagnostic feature for benign polymorphic adenoma is that the matrix material, the border is very indistinct and fibrillary. Additionally, you will see a very tight relationship of myoepithelial cell embedded in this matrix material. So if you see other type of tumor, for example, adenocystic carcinoma, usually the matrix material is very like a dense, and it will push the cells in the edges. So it is kind of different. So you see fibrillary matrix, and all the myoepithelial cells were embedded in the matrix, and we do not see any atypical cells. So this is diagnostic for benign polymorphic adenoma. So for the diagnosis of benign polymorphic adenoma, I always would remind people that we should look for if there is any possibility that we see some high-grade carcinoma cells in the background, because for the long-standing PA, there might be a chance to develop a carcinoma, X polymorphic adenoma. So occasionally we do see a few cases of diagnostic specimen that we see polymorphic adenoma and we see high-grade carcinoma, and we suggest it's CAXPA, and in the surgical excision it is a CAXPA. So the next specimen is a thyroid aspiration specimen, 53-year-old female. So the patient visited us last year, and we already signed out in her prior thyroid FNA as suspicious for follicular neoplasm. So she has a big nodule in the right thyroid, around 5 centimeters. So in this situation, usually we don't need a repeat aspiration cytology because the lesion has already been diagnosed last time 1 year ago, so we don't need another one. But sometimes the patient will just hesitate to do the surgery, so they require another like a FNA again. So I had a discussion with Dr. Luis about the case, because in this particular case we do see significant nuclear atypia, in addition to a very prominent microfollicular pattern. So here we also see some dense colloid. So in a long-standing follicular lesion, sometimes the nuclear atypia will be quite prominent. But unlike papillary carcinoma, for the papillary carcinoma, most of the time the nucleus are relatively uniform. It shows this like a diffuse nuclear atypia change, and it won't show like a significant variation in the size. So for this case, I would say it does show some degree of nuclear atypia, but you can appreciate we do see bigger cell, smaller cell. Smaller cells are mostly rounded. Bigger cells sometimes a little bit elongation. The chromatin pattern is a little bit pale, almost like a ground glass pattern. But it does forming these microfollicular architecture. And some of the area we do see very dense colloids, such as this one, within the microfollicle, which is also typical for follicular neoplasm. So the diagnostic criteria is very different for well-differentiated follicular pattern thyroid tumor. In America, in other Western society, some of the people will call these papillary thyroid carcinoma. But here, because we turn not to call the RAS-positive papillary thyroid carcinoma, so I think this is still a follicular tumor. The sonography feature is consistent with a follicular tumor. So I would call this still suspicious for follicular neoplasm. Basically, this is the same diagnostic as last time, and based on the diagnosis, the clinician should at least do a single lobectomy because of the tumor is very big. So at least he should do a single lobectomy. Finally, we have a positive pap smear. So the patient, 42-year-old female, she had a positive pap smear with CIN2 in the other, like a clinic, outpatient clinic, not in our hospital. So after the diagnosis, she came to our hospital at the beginning of this year. So initially, our clinician, they do colposcopy biopsy, which is negative, and they also do a HPV testing, and it shows other high-risk positive HPV. So after 3 months, this is her follow-up specimen for pap smear. So we know that the patient had a positive pap smear before, not in our hospital, and the positive HPV. So on low power, she is 42, so we do see quite abundant superficial cells. We also see mucin in the background, and supposedly there are some like endocervical cell, just like these over here. So we do have visualization of good endocervical component, which means the specimen was well sampled. We do have the T-zone area. So along the smearing direction, so this is the good thing about the conventional smear, that if you find the lesion, most of the time it will show, the lesional cell will shade like along your smearing direction. So this is what we call a tight hyperchromatic crowded group, right? So hyperchromatic, it's very blue, crowded, so the cells are overlapping with each other and arranged in a group. So we do have our reference cell, intermediate cell nucleus. So the nucleus is not slightly, some of the cell is slightly bigger and than the intermediate cell nucleus, but you see the chromatin pattern is really hyperchromatic. So with these fragment of the cells, a little bit difficult to determine whether these squamous cell or these are glandular cells. So remember, when we see a hyperchromatic crowded group, the first thing that we need to do is to differentiate squamous, glandular, whether this is squamous or whether this is glandular. These might be squamous because in the cytoplasm, there are some like a process, And this may be a very, very vague collocytic change, but overall, the cell is relatively polymorphic, hyperchromatic. So these looks abnormal. So if we want to look for the other cells, we just along this smearing direction. So again, just on low power, you see this is very dark. So you have a hyperchromatic crowded group here. So you go to high power. Again, it shows a very similar morphological pattern. You can see the striking hyperchromasia comparing to the intermediate cells. And also the NC ratio is high. And it does show some cyanophilic dense cytoplasm. So this, again, looks like a squamous cell. So now we think that based on the morphology, we might have a high CO. So if we can find something more, some more definite, like a cluster. So along the smearing direction, again, another hyperchromatic crowded group. Okay, so we have quite a lot of these cells. And sometimes the most easy one for the high CO diagnosis is like this. So like a single cell with a squamous metaplastic type of feature, type of matrix, but you can appreciate the polymorphism of the cell, the hyperchromasia of these cells. The nuclear chromatin pattern is not particularly coarse, but the hyperchromatic pattern and like a hyper high NC ratio. So this is a very good focus of high CO. So for this case, we are going to call this high CO. So the patient does not have a prior pap smear. So when we diagnose high CO, we always look for the 5-year like a review from a prior like a specimen. So the patient only had a positive CIN2 smear at the other clinic, and then HPB here, and this is her first smear. So along the smearing direction, you will find these high CO cell. And you can see the differences between the normal intermediate cell. So this is positive for high CO. So that's for all the case today. Thank you.